sitting here having the patient in a neutral spine position, open her mouth. Fairly simple. Mandibular left lateral deviation, which is just what? Yeah, move your mandible left to right, or in her case, left. So when she moves it to the left, she gets an asterisk sign. And it's 5 millimeters, and we'll show you in lab how to measure that. Mandibular right lateral rotation. She can do it. So negative meaning no pain, but she hears a pop. So when she goes to that side, it pops, but it doesn't hurt. When she goes away, it's stiff and it's bothersome. So hopefully some of you are thinking, wow, this is confusing. So is this closing, opening, articular, muscle? Hopefully you're thinking a little bit of that. Passive physiological, exactly the same. So when we lie her down, no muscles, and you'll find today how hard it is to get somebody to relax and grab their mandible and open their mouth. It's tough. So when you did this passively for Jane, you got the same thing. And again, the same thing with left lateral and right deviation, same kind of symptoms. So again, if it's both bothersome and physiologic passive and physiologic active, what do you think the problem could be? Joint. That's kind of what I would be thinking too. Then we look at her joint mobility. So it would fit, then not even looking at this slide, you would suspect that you would have some findings with accessory mobility, right? If you're thinking it's joint, within normal limits. So equal left to right, meaning that when you assess the mobility, which isn't much, so basically you assess a PA, an AP, anterior, a distraction, and a lateral glide, they were all fine. Or Reema's like, what? We're doing all those today. They were all fine. Some discomfort was noted on that right side, but not her asterisk side. Okay, so again, that's interesting. If you were thinking it was joint, you would expect that to be limited, but it was not. Special tests, so the amplitude test, again, there's that less than 30, she was positive. Right masseter, temporalis, medial and lateral pterygoids, and again, I would say, for the most part, unless you're going to a 3 or 4 day TMJ course, it's very hard to palpate medial and lateral pterygoids. They're deep inside the mouth, and unless you know what you're poking on, that's going to be a difficult issue. So I'm not going to hold you accountable to finding those. Masseter and temporalis are pretty easy. Resisted manual muscle testing, so opening mouth, closing mouth, and lateral deviation to the right, all painful. So now you're looking at, okay, we just tested muscles, and they all produced her pain. Now what do you think the problem would be? Doesn't it sound muscle? There's myofascial and articular combined. That doesn't make things easy. So here again, we go down to that diagnosis component. I do think it's some TMD dysfunction. I can't tell if it's more articular versus musculature, but I could say, based on passive accessory mobility basically being negative, it's probably more muscle than it is articular. Why is that? What's our proof? Unilateral orofacial pain. It's one-sided. Is there anything that you guys have read or are aware of that in ligament or bone, that those structures react to stress, emotional stress, psychological stress? Have you ever heard of a disc having a response to emotional stress? No, but what have we heard? What tissue can respond to emotional and psychological stress? Muscle, absolutely. There's all kinds of data on that. So when she says stress makes it worse, not necessarily the grinding the teeth, but potentially the stress and anxiety itself, this could lead you to think, okay, it's likely more of a muscle issue than it is an articular problem. Passive accessory mobility was fine. And then again, the actual manual muscle testing reproduced a lot of her signs and symptoms. So, when you look at that, I think the take-home message is you can't be really clear. So you have to treat your impairments. Okay? So don't forget any impairment that you have. And again, don't try to get stuck in, is this contractile, is it inert? It's both, and treat both. And then again, you're treating whatever one to see whatever your asterisk sign changes with the most. So how do we treat these people? Remove stress-induced activities, implement anxiety reduction strategies, proper breathing, relaxation. That should be not relation, but relaxation strategies. In this morning's group, they asked, another question we could have asked is maybe the relationship with the husband. How are the kids at home? I think getting to the fact of why she's stressed or anxious, is it related to the airline she works with? Is it related to the passengers? Is it the flight she's scheduled on? Who knows? And I think that's important because we as therapists can give proper breathing techniques, because where do you think she's breathing from? Scalenes? Yeah, so primary or accessory breathers? Accessory. So primary breather would be diaphragm. She's probably not breathing from there, per se. So the key thing is if you have her supine and you show her this really neat technique to engage her diaphragmatic breathing, but she's really stressed on the airplane flight, when she gets into with a co-pilot, you know, with some issue or some passengers, is that supine technique going to help her there? No. So you really have to know where she's stressed out and potentially teach her how to do those breathing techniques in those positions. And then typical postural, the relaxation, and I would even say re-education or proprioceptive kind of fits with that. Active oral exercises, so again, making sure she can move her mouth efficiently and effectively. The proprioceptive stuff just means, again, it's combined with postural, meaning that her cervical spine, her thoracic spine, and her lumbar spine should kind of be in relatively good alignment for that to function appropriately. If somebody has a forward head, what do you think happens to the mandible? Does it protrude more? Yeah, does that potentially throw off mechanics of the TMJ? Absolutely. So again, looking at the patient as a whole is really important. Okay. All right. So I think it was neat to start kind of with the patient at the end, because those are things that you would be looking for. Now we'll kind of go into this, but before we do this, I gave the morning group 30 minutes, so 15 minutes per partner to go through cervical spine active, cervical spine passive, and passive accessory intervertebral motion testing. This is good practice for the final, so I would really treat it as you're my patient, go through it, go through those things quickly, and time yourself and make sure you can get that done in 15 minutes. So again, active range of motion plus overpressure, passive range of motion, all those planes. This includes screening for AA and OA, prone, palpation, centrals, unilaterals. Okay? Let's start with that, 15 minutes per person, and then we'll walk around and kind of give you some feedback. Okay, so that's in centimeters, so just add a 0, and that'll give you the millimeters on that. And all you're really measuring is the maximum opening that they can do. Now, it's going to depend on what you tell them to do. So, like this morning we had somebody here that's really painful with opening, and it sounds slightly irritable. So do we want somebody like that opening up as wide as they can? No, I think we got to be careful about irritability. So it'll be your call whether or not you're going to have them maximally open as much as they can, or potentially a lot of the times just open as much as you can, probably before it hurts or before you feel like that sensation of a click is going to happen. Okay, so that would be completely fine for somebody that might be on the more moderate to severe irritability, just to get a general assessment. So when they're opening, there's a couple things you can do. You can, if you had a stethoscope and they said that it clicked or popped, but you can't hear it, you could put a stethoscope on the TMJ joint to hear it. Because the worst thing you could do is blow that off, right? Especially if that's a chief complaint that they have and say, oh, I don't hear it. I don't hear it. Show them that you're going to get a stethoscope and try to listen to it. And you might be surprised on how much you can hear with a stethoscope there. So go, their normal side and then their symptomatic side and see what happens. The other thing you can do is you want to measure it with the measuring tape. I would suggest using gloves for all of these patients. Okay, so anytime you're going to be doing any of this stuff, put gloves. There's gloves on the back. And I would suggest that all of you do that here. I would suggest that you wash your hands. Again, there's been a lot of people sick, not just this class, other class. People have used these rooms, so just be really good. Nobody wants to be sick next week. Although Dustin said it was okay if Jimmy was sick next week. So make sure you use the towels and everything, and just, because we have the towels, so make sure people don't expose themselves to other stuff. So you're going to have gloves on, and you're basically going to wipe down the tape measure with an alcohol swab, because they were all used in your classmates the class before. So make sure you clean the tape measure with an alcohol swab, and basically when they open their mouth, you're going to measure from the top of the what? Or the bottom of the top teeth to the top of the bottom teeth, that's it. And what did we say was kind of a number that we might be looking for? 35 to 45 is normal, right? But people that have problems are going to be in the 20s. That's easy, super simple, right? So that's mouth opening with the option of auscultation. We do ask for asterisk signs, so as they're doing that, how does that feel? What is happening as they do that? So I'll just go through them all and then we can practice them. Mouth closing, do you think you can measure that? No, so you just want to have the patient bite down as hard as they can. And what are we asking if they do that? Asterisk sign, how does that feel? Okay. For the most part, it probably is not painful, but again, it could be something that you could note, and I'll show you in a second what that means. Mouth protrusion. What is protrusion? This goes with Chris's mandible. Yeah, so the mandible going forward or backwards? Forward. So how would we measure that? Teeth, right? Somebody said, what if they're missing their teeth? You gotta be creative with that stuff. And even Monica asked, well, what if the lines in between the teeth, when we look at deviation or crooked? I'm like, you just make it, you make it. So with mouth protrusion, you basically get a baseline of symptoms, how are you doing here, and then I just want you to kind of shove your chin out as far as you can towards me. And then you're basically measuring kind of that displacement. So it would be from the teeth that are on the top to the bottom teeth, okay? And then you get millimeters on that, or a measurement. Pretty simple. And what I've noticed and what's been helpful is that if you get the tape measure and you fold it up so that you have just like a 5 or 10 millimeter increment and put that on top, that's easier to do. Oftentimes in clinic we'll use a tongue depressor and just mark on a tongue depressor the movements, and then later on we'll measure. That's a lot less invasive than sticking a tape measure in somebody's mouth. Okay, so you have both options on that. Do we have tongue depressors here?
I think so.
I didn't see any, so okay.
Do we use these too?
Didn't? Okay, so if you guys can find them next door, feel free to use them. Retrusion is basically the same as retraction. Again, difficult to measure, but we're really just looking for symptom recreation. And if there's a over or under bite, you can kind of look at some of these things. But basically, having them push their chin, retract their lower jaw as far back as they can. Most people won't have most motion with this, or a lot of motion with this. So we don't necessarily measure retrusion. So far we measure what? Opening and protrusion. And lastly, lateral deviation we do measure. So that's having a patient bring their lower jaw to the left or to the right. So again, they keep this stable, and they would shift this that way or that way. How do we measure that? Teeth.
Top, bottom.
Teeth. So you can kind of pick a midline point between, where's the skull? You can kind of pick a midline point between here and here. And if they do that, and keep that same midline point and then measure the difference. Okay, so again, not really scientific, but you're looking for left to right motions. What they found is that there's typically a 4-to-1 ratio. For about every 4 millimeters of opening, there's about a millimeter of deviation. So do you think you'd have, for a patient, would they have more lateral deviation or opening? Opening, right. So usually it's about 35 to 45 degrees opening, maybe anywhere from 8 to 10 for lateral deviation. Okay. So this is something that I drew up in terms of how to measure or record these things. So grab one of those pieces of paper that maybe has your patient chart on there, and then right on the back, draw this out, because you're going to record your partner's measurements. So basically I draw a line here and here, okay? In general, this is going to be protrusion. In general, this is going to be opening. This is the patient's face looking at you, so this would be the patient's what? Right, and this is the patient's left, so this is deviation, and left deviation. Okay? So with opening, again, you could measure 35 millimeters. Great, no problem. With protrusion, 6 millimeters, great, no problems. With left lateral deviation, 10 millimeters, no problems. And then with right, 12 millimeters, no problems. The other thing that you can start to look at is that when they open their mouth, you may see a deviation, which a few of you potentially have. So that deviation, if you see when they open their mouth and their mandible goes to the right, that's what this arrow is for. It's not scientific, it just kind of denotes the direction, so that if I pick that chart up the next day, I could see, let's say it looked like this. 22, asterisk, 4 out of 10. With that, what does that tell me? It's limited, it's painful, it is their asterisk sign, it's 4 out of 10, and it's going towards what direction? Right. To the right. Okay, so it's a nice way just to kind of document in the chart how that would appear. And oftentimes this might be limited as well. Asterisk sign, 6 out of 10. Okay, so again, you can use this as a documentation tool as well. And that's in the lecture handout. So as you go through each other, as you're taking some measurements, kind of write it in this format just so that it becomes kind of a good pattern to follow. Okay? All right. so gloves on. Somebody's the patient. Wipe down the tape measures. There's alcohol swabs. Go through opening, right? How are you doing? You can auscultate if you want to. Go through closing, which you don't measure. You just see how they bite down. Go through protrusion, retrusion, which is retraction, and then lateral and left and right deviations.
Is the air that goes up and up
For protrusion. It's hard. So retrusion is hard to see that small deviation. You're looking at probably 3 millimeters of movement. So if you're good enough to pick it up, absolutely. And the likely thing is you're going to see more of these patients than you will wrist and hand. So, yeah, so that kind of puts a little bit different spin on it. Have fun. Breath mints, please. Breath mints, please. So it's going to follow basically the same principles. We're going to have the patient in supine. So again, it's a little bit more comfortable for them. I'll show you on this guy, and I did detach this. I didn't break this. The morning group thought I broke that. It actually detaches. So basically, for mouth opening, you want to grab the mandible in this direction here, get the patient to relax, which is really hard to do, and then just open in that direction. You've already actively measured them, so you kind of know how many millimeters they have. So again, like I had Fernando in the morning when I was trying to do this on him, and he was just like, but actively he could do that. So I said, okay, just open for me, relax, give it to me, relax. Then he relaxed, and then I could kind of take him into that position. So I think you'll find it's good to kind of go through that fact. If somebody's clenching their jaw or doesn't want to do that, it's a good experience to go through that. So again, you'll go through opening the mouth, closing the mouth. Again, if they're in a rest position, it's just this. It's not much, right? So have them start kind of in an open rest position here of their mouth, and oftentimes that can be the tongue just against the palate. It's a good cue for a neutral kind of open jaw position, and then take them into opening, take them into closing, and again, I'm just manipulating the mandible with this, and my hands are stabilizing basically the skull or the head. Okay, so that's opening, closing. Protrusion gets a little bit difficult because you got to get your hand in there. So for protrusion, one hand is going to stabilize the skull, open up the mouth. Thumb with the glove on is going to grab right here into the anterior aspect or the posterior aspect of these first couple teeth, that first row. And what do you think you're going to do? Yeah, just pull like that. Okay, now again, you've measured that, so you know how many millimeters they have. Probably, this is an over-exaggeration, but that's all, that would be a problem. That's hypermobility, but that's all you're trying to do, okay, to go through protrusion. Retrusion, again, we don't necessarily test it or retraction, but that would basically be this, which, it's interesting, nobody asked me in clearing the OA joint, what about OA flexion with people with TMJ problems? So think about that, and we'll revisit that in a second. So we have opening, we have closing, we have what? Protrusion, retrusion if you wanted to, but again, I think that's okay enough to assess in this position. What's the last one? Lateral glides. So again, when you come in, if I wanted to do a lateral glide on his right side, I come in here, and basically I'm on the inside part of the molars, and that's it. Okay, yeah. Ouch. Right, so it's a glide into that direction. Again, 8 to 10 millimeters is what most people are. And then if I want to do the other side, open, thumb goes in here again towards the molars, and it just glides that way. Some people will do this in sitting. So if the patient's sitting, and oftentimes it might be easier, depending on the hand placement, to do it in sitting. This guy's got a loose jaw. Okay, so go through at least opening, closing, protrusion, and lateral deviation. And I think the main thing is being comfortable with putting your hand in somebody's mouth, and making sure that you have all the hygiene component with the gloves and all that stuff too. All right. Give it a try. It has a lot of motion. You're probably not distracting them a lot on that side. So distraction, like everything else, is good for stiffness, for pain relief, those type of things. But somebody like poor Haley, who's popping out a lot right now, pulling her into distraction is probably not an appropriate thing. Okay, so again, I don't think you necessarily need to practice that, but just know that your hand placement would be on the molars, and that you would just go down in an inferior direction. And we could do grade 1, grade 2, same kind of thing for pain modification. And then the other glides are basically what you did. The lateral glide is what you did already when you looked at kind of that lateral deviation. You would just glide it, so it's a 2 for 1. It's the same thing. And then this anterior glide is basically protrusion. Right, so it all mimics itself. The active motions mimic the the passive physiological, and the glides kind of mimic the passive physiological motions. Okay, so again, when you're looking at the glides, the AP and the PA are in sideline, and all you're really doing is trying to push down, and I'll show you guys that one in a second. The caudal glide is basically coming onto the molar and just doing an inferior glide going downwards. So you're not pulling forwards with this, you're going down towards what? Their shoes, in theory, right? So you're really distracting it downwards in that direction. The anterior glide is basically protrusion, but now you're just gliding it. So again, you're assessing the joint component. And then the lateral glide is what you've seen before, okay? And that individual is Roger Carey. So that's the cervical arterial dissection guru there, or dysfunction guru guy. So let me show you this one really quick. Again, the joint is here. They're in that position, likely like this, right? They're on their side, one arm's underneath them. You're basically going to find kind of the inferior or the posterior aspect of the pole, this portion of the mandible, double the thumb up position here, and you're going to do it posterior to anterior. So a lot of people this morning were doing more of this, straight down. You're not going to go anywhere straight down. It's really a glide going towards kind of the mouth opening, right? So if this is the position, I palpate TMJ. If you don't know where TMJ is, have them open and close. You should feel it kind of do this over your thumb. Then once you've found that, 2 thumb contact, and then this is the posterior to anterior. And then again, you flip on the other side, feel that anterior aspect of the TMJ, and push this way. You guys can practice that if you want, but it's pretty simple. I think the big thing is don't push down. It's not a PA in that direction, it's more on the oblique axis. Pretty straightforward. All right.
Diagnoses that Dr. Leal already lectured about, and just touch on some of the ways that we can treat. And I always like to look at the tissue. So looking at each diagnosis, what is the actual tissue that's involved? So we treat the tissue. How are we going to treat it? And then what we can do to follow up with the patient. So, Rima actually has some issues. Okay. Perfect. So we're going to start with immobilization. So there's a lot of different diagnoses that can involve immobilization. What are a couple? Fractures. Because we cast them, so they're immobilized for 6 to 8 weeks. What else? Sprains. So sprains, we might just put them in a brace of some sort, or physicians might put them in a brace, immobilized for a little bit. What else? What else?
Ligament.
So ligament sprains too. So ligaments. Good. So sprains, fractures. Post-op. So post-op, surgical. So we just had some kind of surgery, so we're going to immobilize, maybe some kind of splint again. And then sometimes people will just self-immobilize because it's painful, they don't want to move around, so they're going to self-immobilize and just not move very much. So those are some of the things that we can talk about. After immobilization, even though there's all these diagnoses, what are some probably common threads as far as tissue impairments? So after any time you immobilize, what are some things that will go on with your tissue? Range of motion deficits. So it could be either muscle or it could be joint. Atrophy or decreased strength. Decreased muscle length is what I was saying. What? Scar tissue. Okay. And then how about edema? Edema happens a lot. Okay. So those are some of the impairments. They might be all kind of common for any kind of immobilization, but we want to figure out which tissues are really problematic and then how to treat those. So of these, what are we thinking maybe we want to start with? These are kind of common impairments. So you've got your patient who just got out of a cast, 8 weeks, seeing you 3 days after cast removal. So these are some of their tissue impairments. What do you think you'd want to work on first?
Range of motion.
I think edema, range of motion. So edema can often cause your range of motion deficits and pain. As any of you who saw Jeff after he was post-surgical, you can see a lot of that edema takes up a lot of room, so he can't have range of motion. Also pushes on some of his muscle tissue, pain receptors, and causes pain. So edema might be one of the first things that you want to treat. Next slide, please.
Yes, yeah.
So, can I use a little of this on you? I'm just going to demo a little. I'm not going to use very much. So if she's got some swelling all through here, so what kinds of techniques do I want to use? I want to get in transverse friction, probably some effleurage or milk so I can as you know, up towards proximal arm, getting all around the joint, not just on the top part, but all around the joint to try to flush some of that fluid back to her heart. So make sure you capture all of that, and you got to get in there a little bit. You can't be super soft here because that's not going to do a whole lot. So facilitate that drainage. So now I've done this about 5 to 8 minutes. Swelling looks like it's gone down a little bit. She says, oh, that feels so great. I actually feel like I can feel my arm a little bit. So now I want to do range of motion. So range of motion, I tend to do a little bit of passive, gentle passive. So if she's really stuck, like this is her limited active, this is her limited active. So I might do a little just passive. Does that feel okay? I'm going to start out pain-free range first because if she's 3 days post-cast removal, she hasn't moved this very much. So I might move it just a little bit. Does that feel okay? Sure. All right. So I can get a little passive range here with my joint, but what if I want to do the joint, so accessory mobility? If I have her, say, stuck in extensions, she doesn't move very well in extension, what kind of mobilization can I do at, say, proximal carpal rail, or actually the distal carpal rail? So extension, we know the proximal row goes with my hand, so it's going to go dorsally. My proximal row is going to go volarly. So they're going to go opposite. So distal row goes with my hand, proximal row goes opposite. So if I won't have her limited in extension, I can probably do a little volar glide of my proximal carpal row to try to get her to move a little better. So I do that for a little bit. I feel like it's moving. I'll probably do maybe day 3 after cast removal. What grade? Maybe 1-2s if she's like, it's just a little uncomfortable, it's not terrible, but because she is still edematous, I probably don't need to get in there too much day 1. So I might just do 1s and 2s, but now if she's 3 visits in, she feels good, edema's down a little bit, now I can do my 3s and 4s. So I can actually work to try to get range of motion. So now my joint's moving a little better, her range of motion is better. I tend to follow up all of my motion with active motion. So I've done some passive range, she feels okay. I do some joint accessory. I recheck, she's gained some passive range. Now I say, I want you to help me do this motion, and then I'm going to give you just a little overpressure at the end. I'm going to do this about 5 times. So I'm kind of 80-20, she's doing most of the work, and I'm just giving a little bit of help at the end and giving a little overpressure. Because if I've gained 15 degrees of motion, I want her muscles to find that range of motion so that her muscles can move into that range. I may even have her go up until she can. So hold it right there. I'm going to have her push this way and just some isometric stabilization. So neuromuscular re-ed in that new range of motion. So I might push all different directions, just resist me, so that her muscles can help her maintain this range of motion. And then of course I'll send her home with active range of motion exercises to just keep that range. So I've addressed her range of motion, I've addressed her joint mobility, and some edema. Now if she's into maybe 6 visits, feeling pretty good, edema's down, we can really start on some strength. So now I can do something where I just use my own resistance. This is always a nice one to start with because I can judge how much resistance I need for her and how much she can tolerate. So this isn't the best angle, but I could have her extend and flex. So let's pretend she's off the table. So I could have her extend and flex, and I say, okay, I want you to do this motion. I'm going to resist you as you do this, okay? So go ahead and bring your hand up, and then bring it down. So as she starts to move, I can adjust my resistance. So say she starts getting really weak here, I can ease off a little so she can get full range of motion. I can have her push harder if she's stronger in her range, but I can judge this instead of just throwing her in with a dumbbell right off the bat because I don't know how much she can do. And I also want her to be pain-free. I can have her bring her hand up. Now hold it there, hold it there. Now slowly let me win. So now she's getting a little concentric and eccentric. So I can do that both directions. I can do radial and ulnar deviation. I can give her a hammer and she can do supination, pronation. So she can do all these different strength moves with her hand. Then, after I do a little bit of manual resistance, now I can give her a dumbbell. And I can say, hang on to this dumbbell. And I want her to hang her arm off the table, and then she can do full range of motion extension. And then I can say, hold up here, and then take 4 seconds to slowly lower that down. So So she gets concentric and eccentric on her own. She can flip over and do flexion. So I'm progressively adding a little bit more and more. So of course I can add more weight at some point in time. I can add more resistance. And then I always want to make sure, well, what's functional? What does Rima want to get back to doing? So say she's in a bowling league. She's like, I just really want to go bowling. I don't care about anything else. So I want to start getting, if she's got some finger flexor issues, or I know she has to get extension and flexion in order to bowl, then I might stick a weight in her hand and I might have her do this whole motion of bowling and exaggerate your wrist extension, exaggerate your wrist flexion, so she's getting exercise and she's getting strength in this motion. I might have her grab something and hold finger flexion while she does that too, all functional, because I want her to get to where she wants to be. And I can give her a dumbbell all day, but that's not very functional for her to just sit off the edge. So always bringing it back to what she wants to do, and then making sure that I educate her to go home with reinforcing what we've done here. So that's kind of a general thing of what we can do when you have impairments that have to do with mobilization. So what you'll find, so I think we talked about both ischemic contractures, so I put that up there because that happens a lot when you've been immobilized. So perhaps you've had direct trauma somehow and you basically occluded blood vessels. So you have so much edema that it's now occluding your blood vessels, and so you don't have flow to drain. So sometimes when people get casted, they get casted while there's still swelling going on, so that swelling will push up against that cast, occlude their blood vessels, and then they start having numbness, tingling, pain, discoloration in their fingers. So they may come to you while their cast is still on, or perhaps it's just come off, and they've got discoloration, pain, and they're like, oh, I can't even feel my fingers anymore, and you're thinking, there's some amount of edema that's normal, but that's not so normal. So this is one of those occasions that I'm just putting this up there to be aware that your course of action would not necessarily be to treat, but you might recognize that something else is going on, and we probably want to refer back to the physician. You just say, hey, you just had your cast off, or you were casted pretty early, you had it on for 6 weeks, you've had this progressive numbness and tingling, it continued to swell. I think maybe we should go see your physician and see if there's something else that's going on. So just something else to keep in mind. Okay, trigger finger. So pretty common that you might find some trigger fingers. So this is where their flexor sheath is getting caught. So they sometimes can't flex, they can't extend, their tendons just get caught. So what I've seen sometimes is just, your tendons run through here. So I can, if it's just one finger, I can go along where that tendon is and actually just move against it to try to basically shove that tendon aside, get it to move a little bit more. Some tendon motility is what I call it. So I can go both ways to get that moving. I can try to extend, so it's almost like nerve mobilization, but it's tendon mobilization to try to get it to floss a little bit in there. I can try to get up along her muscle belly, because maybe her muscle belly has gotten tight too. As far as strengthening type things, do I want to give her finger flexion or finger extension? Probably more extension. Odds are she's going to be weak flexing because she gets stuck and can't really do that. But at the same time, I don't want to give her finger flexion exercises because that'll just reinforce her issues. And then we have something called reciprocal inhibition, where if you exercise one muscle, the opposing muscles will reciprocally inhibit or relax. So that could be part of my plan here, is if I get her to work her extensors more, that could reflexively inhibit and calm down some of the tightness that could be going on in her finger flexors. So this is treatment perhaps before surgery. I just had a patient a couple weeks ago who had surgery for this, and so she built up a ton of scar tissue. So she has scar tissue where the surgery was, and while she's got a little bit of motion now in her fingers, that scar tissue is now bound up so much that it is almost impeding her tendons. So same idea, I can still try to floss a little bit, or you can get into the tendon. And I found that if you get into the soft tissue and say this is her tight area here, I like to put a little low load pressure on it and then go kind of around the clock and feel which direction I feel most limited. And if I feel most restriction soft tissue wise in one direction, then I'll push into that direction. And I might do little circles here to try to get that tissue to loosen up. There's also a good taping technique that I made to show you now because I forgot last time. So if she has, say, scar tissue right in here, there's a great technique that you can use using kinesio tape for scar tissue, and this is scar tissue anywhere. Scar tissue tends to relax a lot based on a constant low load pressure, which is why we do a lot of that just point tender scar tissue mobilization. So that's the idea of the kinesio tape, is it's elastic tape. You can stretch it out, so every time she moves, that elastic tape is going to do this across the scar tissue and relax that scar tissue with that low load pressure. So I've made this tiny little thing, and you can make it as big or small as you need, and I've cut every side and every corner. So I'm gonna split it down the middle, and I'm gonna put this X, the middle there, right across where her scar tissue is. So we'll pretend that it's right there.
That's a masterpiece.
It's pretty awesome when it's big. Looks like a big tattoo. So then I'm gonna take all of that off, and then I'm gonna stretch every, I'm gonna try to individually stretch every piece here. I kind of stretch it out as much as I can. This is the one time where you don't, it's okay if you have no stretch on the end. And she's got lotion, so it's not really sticking. But I stretch it out, so it looks like a nice tattoo. But now the idea is her scar tissue is right in the middle, and then she has elastic tape pulling on it, so every time she opens and closes, it's going to keep pulling on that underlying tissue to release that scar tissue. This actually works really great post-op. If it's still open and it's not completely closed surgical, then you probably don't want to do this because you don't want to open it again. But if that is a well-healed incision, you can put this across it and it works really great, like say total knee arthroplasties. So that's something you can do post-surgery if you've got some scar tissue. Yes, sir?
Does that work well with, like, the scar tissue is a little bit higher up?
You can do it anywhere, anywhere there's scar tissue.
You're just going to be pulling more, like, say it's up higher in the finger, you just have to pull more.
You probably have to just angle it so that it has more ability to pull. Yeah. All right, so that's trigger finger. De Quervain's. So De Quervain's is a tenosynovitis. So what tendons are involved with De Quervain's? Extensor pollicis longus?
Right.
Abductor longus and EPB. So extensor pollicis brevis, abductor pollicis longus. So if you look at your snuff box, brevis is going to be the most volar one, and then abductor is going to be just lateral to that, a little smaller though. So they're the two that go through the first tunnel. So tenosynovitis, basically your tendon's really irritated. So people who have maybe, I see a lot of people who are weekend builders. So they're doing something on the weekend, they're hammering a ton, and so they end up getting a really bad tendonitis across these two tendons here. So what I can do is that same sort of thing I did with the flexor tendons, is I can go along the tendons and just try to mobilize a little. Sometimes, even in a short amount of time, it might just create some inflammation and some scar tissue in there so it doesn't move very well. So I can move along the tendons, do a little bit of mobility here. I know with this, it probably extends all the way into the muscle belly. So I can take, so I can go along the muscle belly here, and I can do something called active release. So I can lengthen the tissue while I go against the muscle grain. It's usually a little uncomfortable, but it works pretty well. So I can do something like this to lengthen, keeping in mind that every time I lengthen her tissue, it's probably going to be uncomfortable, so I don't want to make it where she's grimacing every time. I call that the positive switch test when they go, every time you do it. So I just want it to be nice and comfortable. Are you okay with that?
Yes.
Okay. So after I do that a little bit, then I can also retest and say, well, it hurt when you just moved it a little bit. How does that feel now? Oh, fantastic. It feels better. So I always want to test and make sure that I'm barking up the right tree. So I can do some of that. I can do some gentle tendon mobility. And then with this would be a time that perhaps I would actually give her some kind of flexor exercise, because her extensors and her abductors are really painful. So if I can give her a little bit more flexion, that might reciprocally inhibit her APL and EPB. So another thing that we can do for strength. So keeping in mind with all of these, your target tissue. So for De Quervain's, it's your APL, EPB, trigger finger, flexor tendons. So addressing your specific target tissue. And once you figure out that target tissue, you'll see a lot of the impairments that are kind of the same. All right? Oh, so I forgot to say education. So keeping in mind too that I'm gonna tell Rima, I know you really wanna build that dollhouse for your daughter for Christmas, but perhaps you can just lay off it for a little bit. We gotta let it heal, we need to ice it at home, you can do some gentle range of motion to try to lengthen that out. I could even teach her to do a little bit of tendon mobility. She can do that on her own too. And I tell people, every stoplight you come to, just move your tendon around a little bit. Do a little of your own soft tissue. Because then I know I've used this analogy already, but if I tell people, your tendon is kind of like a cut. If you cut yourself and you keep poking at it to see if it's healed, it's never gonna heal. So same with this, and you know you've hurt your tendons. If you go back and hammer for 6 hours a day, it's never gonna heal. So ease off for a couple of days, let's see if we can treat it, it'll feel better, then you'll get back to doing what you're doing. Keeping in mind too, as she comes to see me and I know she wants to build this dollhouse, I need to make it so that she can go back and build that dollhouse and not come back to me with the same problem. I didn't even tape. So you could actually tape this too. So remember how we talked to Rima about her extensor lateral epicondylgia? So remember how with kinesiotaping, if you want to facilitate muscle contraction, it goes from origin to insertion. If she has a tendinitis of sorts, I want to do the opposite, so it proprioceptively quiets it down. So with this one, because I know it's an irritated tendon, I could tape right through the muscle belly and the tendons of APL and EPV from insertion down to origin, so I can kind of inhibit and quiet down those muscles. That actually tends to work pretty well too. So I can do that with kinesiotape.
Janice, what position would you put the thumb in while you're taping that to inhibit?
Good question. So all of the tape that you do, you want to lengthen the tissue out. So I would put her this way, and then I would tape from the tendon through the muscle belly. And then I would have her test whatever actions she was doing. And with kinesiotape, you should see pretty immediate results. She should say, oh wow, that feels so much better. If not, perhaps it's not the right modality, or perhaps you didn't tape it right. So kinesiotaping, it doesn't have great research on it and evidence on it, but subjectively it tends to work really well. Okay, lunate displacement. So it tends to move just historically, it tends to get displaced in the volar direction. The lunate, you know, doesn't have any muscular attachment, so it's pretty mobile. And I know some of you were in here to see Amani, who had elbow pain, and it turns out she actually had lunate issues. And for those of you who did see her, I emailed her last week and she said she's doing a lot better. So that's kind of nice. So we talk again, the lunate is in the proximal or distal row? It's in the proximal row. So you follow it down from the third metacarpal, you find your capitate, and then just proximal to that is your lunate. You can probably mobilize and move your lunate around. It moves quite a bit. So you can imagine, as we said earlier, if it is in the proximal row, if I extend my wrist, that lunate should go volarly, so it slides out of the way. If I flex my wrist, it should go dorsally to slide out of the way, to give me full range of motion. If for some reason it is stuck, say, dorsally, and I go to extend, my carpals aren't moving out of the way, so it could be painful. So painful when I extend my wrist, painful if I weight bear on my wrist, if I try to do a push-up, if I try, like in Amani's case, she does weightlifting with her wrists in extension like this with tons of weight here. She's like, I can't hold that either, it just really hurts. So if her lunate is displaced one way or the other, that could be a problem. So if my lunate is my target tissue here, what might I do to my lunate to fix it? It's not a trick question. Yeah, so with Amani's case, she was actually, I think, shifted dorsally. So every time she tried to weight bear, she couldn't weight bear very well because she was getting blocked and it was painful. So we just checked out, if she was stuck dorsally, then I'd want to move it volarly. So, actually I think she was the other way. I think we thought that she was this way, and then after I mobilized her in the dorsal direction, she tried to weight bear again, and she wasn't really that much better. So I just flipped it over and did it the other way, and I could actually after that, I could feel that it was a little bit more volar. So you can do gentle mobilization, so I can get her on her lunate, and I can push dorsally here. So I can just do something like this where I'm trying to push dorsally, and I'm giving a little wrist flexion with that at the same time. I can check her, see how she feels with it. She's like, oh, it's a little bit better. So if she feels better, I know I'm kind of on the right track. So I could give her a little thrust where I go to end range, and then just give her a little thrust, which is what I did with Imani. And then she tested it, and she said she was better. Like there was just a little bit of pain at that point. So I can mobilize that lunate, but right after all that, kind of anytime you improve range of motion, you want to follow it up with something active. So now I've improved her ability to extend without pain, but her big thing was weight bearing. So I can have her weight bear and have her rock back and forth to try to see if that feels any better. And then she can actively do this so that she gets repeated motion pain-free now that her lunate is theoretically in the right place. So she can get mobility on her own so that she can go back to weight bearing and doing all of her other things that she wants to do. So always following up with that. I can even teach her how to mobilize her lunate herself. So she can get in there and she can do that same sort of thing. So I can teach her that too. All right. Moving right along to our carpal tunnel syndrome. Anytime you hear syndrome, it usually means there's a lot of things that could go on. So it's not a really great diagnosis. So just looking at this, or perhaps from what you already know, what are some things that can contribute? Actually, first of all, what's the target, what's the tissue involved with carpal tunnel syndrome? Your median nerve. So it's getting squished in your carpal tunnel. So what are some of the reasons that it could get squished in that carpal tunnel? Inflammation of?
Space, carpal space.
Is the carpal space inflamed?
No.
Is it, what tissues are inflamed? So your flexor tendons, right? So you got to be specific, because if you're not specific, you don't know what you're treating. So inflammation of your flexor tendons, which is kind of the classic, I type all day, I inflame my flexor tendons. So flexor tendon inflammation is one of them, probably the most common. What else? So your transverse carpal ligament. On that same note, so the flexor retinaculum. And then what we just talked about, your lunate. So say if your lunate here moves volarly, it could also take up space in that carpal tunnel and squish down your median nerve. So we just talked about how you can mobilize your lunate dorsally to get that out of the way. Tendons, so if my tendons are inflamed, we gotta decrease that inflammation. So ice massage, I could ice in general. Iontophoresis tends to work pretty well with some superficial tendons, so I could try that. I could do some mobilization. I can do that same active release technique, so I can try to get some of her flexors to relax a little bit. So I can stretch those out. What about my education? So she has to work 8 hours a day, 40 hours a week, typing on a computer. Ergonomics. So you'll see a lot of times people who have carpal tunnel issues, it's because they're at a desk, but they have horrible posture, or their ergonomics are all off and they're down here, or they're way up here, or something's going on where they're compressing that carpal tunnel. So what I would probably tell her to do is make sure you get this ergonomics. I'd probably look at her posture too. I know that she has to sit upright like this, so maybe I can think of something that she can do functional-wise to strengthen so that she can stay in this position and not rest down here and put pressure on that carpal tunnel while she types. So I can maybe have her up here, see how long she can go for maybe 20 seconds at a time, 30 seconds at a time, and she can push into maybe something of resistance, so a little bit of putty, so that we can work on her finger flexors as she's in this position that she has to type. Actually just thought of this morning. So if you're typing here, I can maybe put a little bit of a weight strapped across her wrist so that she has to have a little bit of weight as she has her arm up, so she can go up and down like this as she's got a little bit of weight here, because I know she has to stay up here in order for herself to type. So I can have her do something like that with a little weight here so she can build up her strength. So again, anything that has to do with her function, what does she need to get back to doing? I want to make sure that she can do that, and I prep her for that so that I don't just give her some exercises, send her back to do what she wants to do, or say she has to go to work, but it has all my exercises, doing dumbbells, anything, doesn't have anything to do with what she actually came in here for. Because I'm basically sending her back to the fire, and she's going to get hurt again, and then she's going to come back and see me again, which is great job security, but not really what we want to do. So always thinking of ways that she can go back to what she wants to do, but I can help her modify. And that kind of goes along with everything. So say Imani, who had her pain with weightlifting. I think she's one of those people that I could tell her not to do it, but she'll probably go do it anyway. So I need to help her modify that. So can I have her try to keep her wrist neutral when she does overhead lifting? Can I have her do knuckle push-ups instead of weight-bearing wrist extension push-ups, fingertip push-ups, something else where she's not aggravating and putting herself in those same positions, but she can still work out. Because like I said, most people are gonna go do it anyway, and then you'll never get them better. So always looking for ways that you can modify their activities so that they can get back to what they're doing but not hurt themselves again. All right, so, oh, and then transverse carpal ligament. So that attaches over here to my pisiform. So I could mobilize my pisiform because it's pretty mobile. So if I think that transverse carpal ligament is really tight and that's what's compressing down on my carpal tunnel, I could mobilize my pisiform. So technically that's medially in anatomical position. So I could mobilize it medially, maybe do some grade 4s, to see if I can stretch out that transverse carpal ligament a little bit. I can teach her to do that herself. So I try to give my patients a lot of tools that they can follow up with, because as much as I love my patients, I hope I don't see them forever, and I hope I never see them back here again. So I want them to do a lot of things on their own so that they can be independent. So I can teach her how to do that too. And then, of course, following up with the ergonomics and everything else that she can get back to whatever it is her job that she can do on her own. Okay, lateral epicondylgia. So this is something that Rena actually has. Did you get it better after all that taking?
Yeah, I don't feel like doing it.
Yay, let's see if we can make it green. So, lateral epicondylgia is, what are my tissues involved? All of our extensors, right? So our extensors, we want to make sure that we treat that target tissue. So if I have to do a little bit of active release again, I can do that. So I can move her into flexion as I do some extension. I have found that a lot of times, and I think I posed this question to some of you guys in lab, if you have problems with your ECRB, why would you have finger flexion problems, grip problems? Because you'll see that a lot. People who have lateral epicondylgia, they have no grip strength.
You need your extensors to stabilize your wrist.
Exactly. So you need your extensors to stabilize, because if you grab anything, you'll notice you don't grab in wrist flexion, you grab with slight wrist extension. And that's because you have to have stability of your wrist extensors in order to have a good, strong grip. So if these guys don't work very well, I'm not going to have stability, so I'm going to have either weak or even maybe painful grip strength. So if I can work these guys out, I can help with that wrist extension a little bit. I found that if you stabilize distally across the radius and the ulna, that will give you some external stability so that their grip strength improves, and that actually does almost that same thing that that distal brace does for lateral epicondylgia, and it changes the line of pull. So I found that that works really well. So I think some people got to see this. I like to use kinesio tape instead of cover roll. I like that elasticity. So with a patient like that, what I might do is I also like to have them spread their fingers out a lot. So I try to tape as close to the joint as possible. I stretch it out probably about 50%. And remember, the idea with kinesio tape is you never really want to have stretch on the ends of your tape because that could give them a blister. Otherwise, though, I stretch around it, no stretch on the end. And this is more or less my cover roll. And then I take leukotape. I think leukotape is a lot firmer than regular white athletic tape. So I tape it down here, and my idea is I'm trying to compress the radius and the ulna together as I stretch. As I stretch and tape. So now I give her kind of this distal brace, and then I can have her do her typing motions, her weight-bearing motions, whatever the case may be. I can even resist wrist extension and see if that's helped. A lot of times just giving that stability has helped out a lot. I can then tape, and I think I showed you guys already, taping for lateral epicondylgia tends to work really well. Same idea, so if I want to quiet down this muscle extensor bundle, do I tape origin to insertion or insertion to origin? Insertion. Insertion to origin, and I need her wrist flexion so that she can stretch out the tissues. No stretch on the in. Down. And then with that 10% stretch on the tape, I just peel it right off along the muscle belly, up to the end, and then I tack it down without the stretch. Tack it down so the adhesive works. And usually you would clean off the skin so it didn't have a lot of goop on it. But this also tends to work really well with lateral epicondylgia. The next one is golfer's elbow or medial epicondylgia. Same idea though, you're going to treat the tissue the same. You can tape the same way as well, but just looking at your target tissue again. All of this is I'm going to send them home with probably some stretching, whichever way that is, and then whatever function they have to do too. So always following up with what they want to do after that. I think I'll show you a carpal tunnel tape. I'm not like crazy tape happy, I just think it works really, really well on people. And it's a good adjunct. Somebody asked this morning about bracing, so a lot of times people will get prescribed a carpal tunnel brace. And my personal theory is I try not to brace people as much as I can. I'd rather have them strengthen, do whatever they have to do instead of a brace so that their muscles are doing it versus a brace. So with this is kind of a nice little adjunct. So carpal tunnel syndrome, she's got inflamed flexors, so the last thing I want to do is have her extend so much that it makes it really uncomfortable. So I'm actually going to tape her so that she gets a little bit of a pull, almost into a slight flexion. So I have these little tails here. The middle part I'm going to have no stretch on it because that part's going to go right over the carpal tunnel, and I don't want any stretch or any elastic pull across that irritated carpal tunnel. So no stretch there, but then I'm going to put her in a little bit of pain-free extension and pull that tape up the flexor belly. So by doing this, what am I doing with this part? What's it doing to the flexors? Inhibiting, because I'm taping from insertion to origin. So I can inhibit those flexor bellies. Then I'm going to take my tails, and I'm actually going to put 50 to 75% stretch up the hypothenar eminence. And same thing up the thenar. Oops. With still no stretch on the ends. So instead of stretching out this way, compressing that carpal tunnel, she's got a little proprioceptive feedback for this to happen. I've taped a lot of people with carpal tunnel issues with this, and they said that helps out a lot too, especially when they get back to work. So those are a couple of techniques, and I think our take-home, so our take-home message is, so you're looking at all these different diagnoses that we've talked about. So everything from trigger finger to epicondylgia to post-surgical immobilization. They all seem to have kind of a common thread: range of motion problems, possible edema, accessory mobility issues, strength and muscle length issues. So despite all of these diagnoses and the same impairments, you always want to look at each impairment based on the diagnosis though, because as we saw here, all of our tissues are different. So you want to make sure you figure out what the target tissue is based on your diagnosis, and you treat that target tissue. It's not just a blanket statement for everybody. And then treating each person as an individual. So you look at, again, what is their target tissue, what are they doing that's contributing to this problem, and how can you fix that? Delving more into just the tissue, but looking at everything else. Is there postural issues too? And then treating everybody, like I said, as an individual. Always looking at function. Educate your patient, because if you see them for an hour and they walk out of there feeling awesome, and they come back to you 2 days later and they're like, oh, feels just like it did when I first came in, this isn't working. Well, then they come to tell you that they didn't do any of their exercises because you didn't give any to them. You didn't give them any instructions afterwards. And they went and they just worked 20 hours working at a computer or playing PlayStation. So no wonder they're not any better. So it's your job to make sure that you educate your patient so they come back better. And then the last thing is be creative with all of your exercises and your treatment. So everybody doesn't just get massage for 10 and 15 minutes because they have a tendonitis. So you guys have all seen Crazy Stupid Love? No. So Ryan Gosling and Steve Carell. If you haven't seen it, you need to go see it. So there's a part where Steve Carell, midlife crisis, he shops at the Gap because he's trying to look really cool. And so Ryan Gosling comes back and he's like, come on, guy, you gotta be better than the Gap. Rise above the Gap. So rise above massage. So don't be that PT that just does massage, 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 and then you go about your way. So rise above just the massage. Be your manual therapist. You've learned all of this stuff. Do your joint mobilizations. Do your stretching. Do everything that you can individual to your patient. So that's basically the take home. Look at your patient as an individual, look at all your tissues, treat, follow up, and educate. That's it.
And as a side note, we tried